Sierra Leffers, the Community Engagement Coordinator for Dysautonomia International, and I have the honor of hosting tonight's webinar. A few housekeeping notes and announcements before we begin. Your video and microphones are not enabled during a Zoom webinar. If you'd like to use the closed captioning feature, please refer to the bottom of your Zoom screen and choose the CC or live transcript option. You can choose to see how you wish to view the closed captioning on your personal device. If you wish to turn this feature off, there's a small area next to the CC button. Go ahead and just choose Hide Subtitles. You can type questions for our guest speaker using the Zoom Q&A tool. Please keep your questions relevant to the topic being discussed and general in nature. We are unable to address personal medical advice questions, and please do not share any confidential information in the questions, as the whole audience may see your name and question if it is answered. Now we have a few other announcements to make. The 9th annual Race to Beat POTS is taking place on Sunday, June 2nd in Westchester, Pennsylvania. There are in-person and virtual participation options available. And if you want to own this year's t-shirt, the deadline to register is tomorrow. We hope you can also join us for our 2024 Dysautonomia International Conference in Chicago this year from June 28th through the 30th. If you aren't able to attend in person, there are 2 separate virtual options available. We have a lot of great guest speakers lined up for the conference, including tonight's special guest, Dr. Cutchins. You can learn more about disconf.org. Now on for the main event. Our speaker tonight is Dr. Cutchins. Dr. Alexis Cutchins is originally from New York City and received her MD from Emory University School of Medicine in 2004. She completed her residency in internal medicine at Weill Cornell in 2007, followed by an NIH Cardiology Research Fellowship at the University of Virginia. She joined the cardiology faculty at Emory in 2012, and over the last 12 years has developed an expertise in the field of dysautonomia and POTS. And with that, join me in welcoming our special guest speaker, Dr. Cutchins. And Dr. Cutchins, please take it away.
Thank you so much. And I'm so happy to be here and hopefully going to provide some useful information tonight. And I hope to be able to answer plenty of audience questions. That's going to be my main goal. I've put together some slides. I'm going to try to go through them quickly to allow more time for people to ask questions and engage. And we'll start here. Unfortunately, the title slide is wrong, so just ignore this. But we'll start here. So POTS is obviously associated with many different syndromes, and I think our audience is quite aware that there are many different symptoms that patients with POTS can have. All of these mentioned here on this slide. They all are interrelated and can influence each other. So connective tissue disease, small fiber neuropathy, autoimmunity, GI dysmotility issues, infection, cognitive issues, cranial cervical instability, tethered cord. These can all relate to POTS and can cause worsening POTS symptoms, but POTS can also worsen these. I'm going to focus actually on the mast cell venous disease, connective tissue disease issues tonight. So POTS is heterogeneous. It responds to there's a variety of responses to treatments. As patients are aware, one medication may make one patient feel well or better, and then it may make the next patient feel worse. So there's lots of trial and error involved. Just to overview what we're seeing with patients with POTS, this is an image that was borrowed from Lancet Neurology review article on orthostatic hypotension, but it's relevant and it helps explain how in the supine position, when you're lying down, your blood volume is distributed more evenly throughout your body, but localized predominantly in the thorax. When you stand, your blood volume drops down into the lower half of your body and leaves the thorax. This causes some venous pooling, central blood volume loss, stroke volume to go down, cardiac output to go down, and then a reflex to occur to increase heart rate back up and increase vasoconstriction to allow blood flow to the brain. In normal patients, 300 to 800 milliliters of blood gravitates to the abdomen and lower extremities with standing, and 10 to 25% of the volume of blood shifts into the interstitial tissues. If you have lower extremity venous disease or pelvic venous disease, which we'll talk about more, you can imagine that this distribution shifts even more, and you have more pooling of blood in the pelvis and in the lower extremities. So today we're going to talk about mast cell activation syndrome a little bit, hypermobility spectrum disorder some, and then focus mainly on the venous disease, which is what I look at predominantly in my research. So mast cell activation syndrome is a spectrum of disease. We see it in most patients with POTS actually, and it can be very mild, just sniffles or not even any overt symptoms, to severe anaphylactic reactions with elevated tryptase levels. But then you can have everything in between: autonomic disturbances, GI symptoms, rashes, fatigue, food restrictions or food intolerances, urinary tract issues, and medication intolerances. And many POTS patients have a variety of these symptoms. So I look for mast cell abnormalities in blood work on my patients, and I look for these symptoms to try to tailor treatment options to patients. Classically, we see episodic flushing with surges in tachycardia and some with orthostatic hypertension or increases in blood pressure. There's this hyperadrenergic response to standing. So your heart rate and your blood pressure go up. We treat mast cell activation syndrome with antihistamines along with central acting agents that decrease sympathetic discharge, and then other mast cell stabilizing medications like cromolyn, low-dose naltrexone, quercetin, luteolin, and alpha-lipoic acid. Mast cell activation syndrome is complicated and different in every patient, but there's usually a range of triggers that can occur. And what we want to do is try to eliminate those triggers from our lives. So this can be anything from pollution, pollen, weather changes, exercise, fatigue, foods and drinks, alcohol, venom from bee stings, infections, mold, or vibration, friction, or pressure. Any of those things could cause any of the symptoms that are on the other half of the slide. There are two ways to diagnose mast cell activation syndrome. One is consensus 1, and one is consensus 2. There are two different sets of criteria that you have to meet to diagnose mast cell activation syndrome. And I focus on the consensus 2 criteria, which is well delineated in this paper by Dr. Afrin and Dr. Molderings, which involves a wider range of symptoms, a wider range of chemical substances in the blood that we can look for, and different markers that we can use to detect or diagnose mast cell activation syndrome outside of just elevated tryptase or histamine level. We can test in other ways for mast cell activation syndrome by biopsying the GI tract and looking for CD117 staining. That if there's more than 20 mast cells per high power field in GI tract biopsies, we usually consider that abnormal. And so mast cell activation syndrome is not necessarily mastocytosis, although aberrant mast cell activation can occur in mastocytosis. Mast cell activation syndrome may manifest with inflammation, allergic phenomenon, or dystrophic issues, and it's probably more common than was previously thought, 17% of the population. So when we diagnose mast cell activation syndrome, we want to identify triggers, eliminate triggers, and then start treatment. And this is just a slide sort of summarizing some of the mast cell treatments that we use. I'm often talking about these specific medications with my patients to try to find the right one for each patient. And then there's non-pharmacologic treatments for mast cell activation syndrome as well, including vitamin D, vitamin C, and some shoot, I just lost the word. Supplements, things. So I focus a lot on mast cell activation syndrome, and I just wanted to touch on it briefly tonight because I think it's important to be able to control those symptoms, control the triggers for mast cell activation syndrome, and treat any kind of triggered responses, because that's going to help us with the overall control of symptoms in general. The other thing that I see often in my patients is hypermobility and connective tissue disorders. And this is sort of part of that triad that we see, which is mast cell activation syndrome, POTS, and I don't know what's going on, and Ehlers-Danlos or hypermobility spectrum disorder. So type 3 Ehlers-Danlos or hypermobile EDS is a disorder of the connective tissue, primarily collagen. It's diagnosed by physical exam, patient history, and family history. Patients have notoriously difficult venous access. Skin is stretchy and thin. And the type 3 HEDS is 90% of the EDS population. They can develop venous disease, venous compressions at the skull base and in the abdomen and pelvis, as well as median arcuate ligament syndrome and SMA syndrome. We use this Baton scoring system, and I perform this on all of my patients, these exams, to look for hypermobile joints. However, this is not the only way to look for joint hypermobility. And I often ask patients if they frequently dislocate joints or if they have had multiple surgeries on joints before. Those are other signs that there may be joint hypermobility or laxity. Frequent popping or cracking of joints is another one, and then lipedema or excessively stiff joints. All of those can be related to an overarching theme of a defect in collagen in these patients. The treatment for this includes primarily physical therapy and strength training. So let's move on to the venous disease, which is sort of my area of interest. As we know, the venous system houses about 70% of a person's blood volume at any given time. And a patient's cardiac output is very much reliant on the venous return that occurs from the venous system. Veins rely on collagen and elastin for distensibility and elasticity, and veins have higher collagen content than arteries. So you can imagine if there's a collagen defect in these patients, it may contribute to venous laxity, distensibility, or compression. What we see in the pathophysiology of venous disease is lower extremity venous insufficiency. We also see iliac vein compression or May-Thurner syndrome and renal vein compression or nutcracker syndrome. And I'm just going to go through these. In the normal venous anatomy, you have this, the superficial veins and the deep veins. The deep veins over here. When they're functioning normally, there are valves in the veins that will hold blood up on each level. So you can see here when a muscle contracts, blood gets pushed upward. And then when the muscle relaxes, there's a valve closure here. And that valve closure is what helps us bring blood flow and venous return back up to the heart from the lower extremities. When the veins aren't working properly and there are varicose veins or incompetent valves, you get dysregulated blood flow in the lower extremities. And you get blood that pushes out into perforating veins and down back into the lower extremities. So if there's an obstruction or if there's insufficient valves in the veins. So as your muscles are trying to push blood back up, they're actually pushing blood further down. So the longer you're in a standing or upright position, sitting or standing, the more blood that pools in lower extremities. Symptoms of venous insufficiency include achy, heavy, cramping, uncomfortable legs, swollen feet and ankles, burning, throbbing, and tingling sensations in the legs. They feel like they're falling asleep easily. You can get muscle cramps, particularly at night. There can be dry and itchy skin, especially over an affected vein. And you get pain that worsens when you stand and improves when you put your legs up. In pelvic venous disease, historically, the clinical features include pelvic pain that's worse in the upright position, pain with intercourse, pain with urination or urinary tract symptoms, low back pain and hip pain, and varicosities of the labia, upper thigh, testicles, like a varicocele in men. In 1949, there was a publication that also reported in these patients with pelvic venous disease, tachycardia, palpitations, and severe fatigue. So that seems to be that related to these symptoms of pelvic pain, we also have symptoms that are similar to what we see in POTS, the tachycardia, palpitations, and fatigue. In May-Thurner syndrome, the pathology there is compression of the left iliac vein in blue by the right iliac artery, which is in red. This you can see in cross-section here with the spine pictured. This is the right iliac vein and the left iliac vein, and the right iliac artery is sort of compressing this left iliac vein between the spine and the artery. This is not a normal anatomy. And symptoms from this can include lower extremity swelling, maybe left greater than right, but it may not be, leg heaviness, numbness and pins and needles, urinary symptoms, pelvic pain, and low back pain. This is a venogram, which is an imaging of one of those veins. You can see here the inferior vena cava is up top, and it splits into the left iliac vein and the right iliac vein. And the left iliac vein here is compressed by the right iliac artery. And you can see this, there's less contrast filling the vein at this point where the right iliac artery is compressing it. There's clearly an abrupt transition here where blood is continuing to try to push up into that IVC, but because it's not flowing properly, you get these collateral veins that occur across the pelvis and they go up the spine. And those veins cause pooling of blood in the pelvis and irritation of the nervous system in the sacrum. They can also cause pain in the going up the lower back and in the spine. This is just another picture of the same patient with an iliac vein stent. And you can see that once the blood flow is restored to the IVC, you have a decrease in these pelvic venous collaterals and the spinous collaterals. Nutcracker or left renal vein compression is another venous disorder that I see in patients. It's usually defined by the superior mesenteric artery compressing the left renal vein between the aorta and the artery. This is normal anatomy here on the left, and then on the right, you can see there's less space there. And so that renal vein is compressed. And then the drawing, you can see how, because the left renal vein is compressed, there's dilation of the gonadal vein. There's backup of fluid because it can't get to the IVC, and that's what causes pelvic vein varices, pelvic venous congestion, et cetera. This can also be seen when the left renal vein goes behind the aorta or has a retroaortic or circumaortic path, and we see similar results from that. In Nutcracker syndrome, classically you see hematuria and left flank pain, but you can have orthostatic proteinuria, abdominal pain, fatigue, and orthostatic intolerance as well. So there seems to be a theme here of decreased venous return causing symptoms that potentially could correlate to orthostatic intolerance, fatigue, et cetera. If you combine these two scenarios, this is a similar slide that I presented before. We'd already discussed that. So how do we treat this, and what does it mean? Are these disorders treatable, and will they help patients with orthostatic intolerance? And the verdict, we don't know, okay? But it's new. We don't have any indications for repairing renal veins or iliac veins in terms of treating POTS or orthostatic intolerance, fatigue, et cetera. You would think that restoring this blood flow would be favorable in this population of patients, though, just to limit that pooling and to allow for more venous return to the heart. So there have been some studies. Dr. Smith and Dr. Rowe wrote this paper, and they did a study on patients with chronic pelvic pain, orthostatic intolerance, and interstitial cystitis, and they looked at their progress after treatment of pelvic venous disease. And you can see here that for pelvic pain, the symptoms in most of the patients improved. If this is 0, patients who got worse are to the left and got better are to the right. With interstitial cystitis, we also see significant numbers of patients who improved. And then in orthostatic intolerance, we can see that there was also a number of patients whose symptoms improved. Some patients, however, did not feel better. So, it's not a fix all for sure. And we don't necessarily know who's going to benefit from this and who isn't. Here's another graph from that paper showing the amount of patients who had, this is their orthostatic intolerance scores. And then post-treatment, how the orthostatic intolerance score decreased substantially. So pre-treatment, it was about 50-50 spread. And then after treatment, there was a significant number of patients who moved into that less than 5 category. Dr. Smith has another publication in process, and Dr. Spencer in Denver has 150 patients after repair of venous disease showing some statistically significant improvements in orthostatic intolerance at 3 and 12 months. So there's data that's coming out. We don't have, the papers aren't there yet, but they're on their way. So what have we found just in our patients? The general estimate of venous insufficiency in the general population is about 7 to 60%. And we find the most common number in the literature is about 40%. It's similar for iliac vein compression. Autopsy results demonstrate between 14 and 39% of all comers have iliac vein compression. So for our patients, we presented at the ACC meeting. We had 4 different posters that we presented. And the first was 130 patients that were seen in our clinic as new consults for POTS or orthostatic intolerance. They may have been referred for long COVID. They may have been established patients with pre-existing autonomic dysfunction. The average age was 35 with 89% female, and 75% of them had venous insufficiency. So that lower extremity valve abnormality that causes venous pooling in the lower extremities. This could be underestimated because some of these patients were not adequately prepped for the ultrasounds, but it gives you an idea that there's a significantly higher number of patients with venous insufficiency in our POTS population as there is in the general population. We also presented the data on 94 patients evaluated for pelvic venous disease, and 77% of them had confirmed pelvic venous disease, either iliac vein compression or renal vein compression. We have a paper in progress right now that's 130 patients with 79% diagnosed with pelvic venous disease. And this is probably conservative. These are also conservative numbers because our radiologists don't always discuss these findings from MRIs and CTs. And so we have to really do a thorough workup with venograms in order to get this data. And not all of the patients have had venograms. So it's possible that the incidence could be higher. These patients had a variety of symptoms, including 62% of them had pelvic pain, 59% of them had lower extremity edema, 58% of them had urinary symptoms, 67% had GI symptoms. So, there's a huge range of symptoms that we found on chart review. The next poster that we presented was 191 patients that all had POTS or orthostatic intolerance. And we looked at the surveys that they filled out for us when they enrolled into our POTS registry. When we asked them about lower extremity edema, either right or left, there were about 60% of the patients endorsed either right or left lower extremity edema, and 73% of patients endorsed pelvic pain. So this is a big number. We also asked them a pelvic congestion syndrome survey, and we had 63% of the patients endorsing pelvic pain associated with standing or upright position, 35% with bulging veins in the buttocks, vulva, or posterior thighs, and 50% with painful leg veins or varicosities. So this is a high number of patients who answered these surveys in a positive way. And finally, we had 16 patients in our system with POTS who underwent left iliac vein stenting for severe compression of the left iliac vein. The mean age was 32, and there were 100% females. And we gave them a RAND 36 survey that was taken at baseline and then at 8 weeks post-stent. The RAND 36 survey is a validated quality of life survey. So we weren't looking for orthostatic intolerance necessarily. We were looking more for quality of life measures. They assess 8 health concepts on a scale of 0 to 100, which included physical functioning, role limitations caused by physical health problems, role limitations caused by emotional problems, social functioning, emotional well-being, energy or fatigue, pain, and general health perceptions. And what you can see here is that in each of those categories, we had an average improvement in symptoms 8 weeks after iliac vein stent. The standard deviations were large, and the range in symptoms, both the lowest level and the highest level, were also very high. So this is by no means a statistically significant or validated technique, but it's just so that you can see that out of 16 patients, we did overall on average have some improvement in symptoms, and this is only 8 weeks out. What I would say in the patients that I've been seeing is that we really see a substantial improvement in those that are going to improve at about 6 to 12 months. So it does take a little bit of time. This is just another depiction of those results with the purple bars being 8 weeks out and just showing some improvements in all of these symptoms in these very preliminary data from 16 patients. So, when I take care of patients with autonomic dysfunction or who come to see me with orthostatic intolerance, I treat them with hydration, salt compression, dietary modifications, graded exercise. We work on medical management with a variety of medication types. I often will treat the mast cell activation syndrome that's there with a variety of strategies. And then we also evaluate for venous disease, both with extensive review systems and with imaging. The imaging includes ultrasounds of the lower extremities. Patients for this test should be well hydrated, and the test should be performed in the standing or reverse Trendelenburg position. And we evaluate both the superficial and deep systems. When we evaluate pelvic venous disease, the gold standard is a venogram with IVUS of the pelvis, the iliac veins, the renal veins, and the IVC. But we can assess this also with an MRV, an MR venous study of the abdomen and pelvis. But diagnostic radiologists are hesitant to report findings. So oftentimes these studies need to be reviewed by a physician who's knowledgeable in this area. CT of the abdomen and pelvis can miss a large percentage of these, and ultrasound of the IVC and iliac veins is a good screening tool, but often misses pathology. And in our hands, which is going to be also coming out in this paper that we're putting together, it's about 40% of the time that a patient does have pelvic venous disease that's missed on the ultrasound of the abdomen and pelvis. So in terms of management, there are non-invasive strategies as well. Many of my patients have heavy menstrual periods and pelvic pain, and I often try to get them onto a regimen that helps eliminate their periods. When the progesterone levels drop premenstrually, the vein walls dilate and relax, and that aggravates venous insufficiency and compression. So there's clearly a relationship between your period and aggravation of symptoms. I usually recommend a progesterone only pill or implant because patients with these compressions can be at increased risk for blood clotting, and we don't want to use estrogen in that setting. You can use non-invasive management. Pneumatic compression works well. I recommend this to my patients to use compression on their lower extremities for 30 to 60 minutes in the evenings. You can see this picture. This is me demonstrating the pneumatic compression, but it helps with lymphatic return and with venous return. So I think it's very good in patients with connective tissue disease and for those patients who can't tolerate compression during the day. You can also lean your legs up against the wall at 45 to 90 degrees for 10 to 20 minutes prior to bed. That's going to help get fluid out of your legs, back to your kidneys and your bladder so that you can urinate and empty your bladder before going to sleep and hopefully have less disrupted sleep. There's also some new techniques coming out, including fascial counterstrain, which is potentially a relief of compression versus an improvement in lymphatic drainage. I'm not sure exactly which one this is doing, but the lymphatic drainage does seem to really help get fluid back into the venous system and back to the heart to improve cardiac output. So this is just a summary of what I do with patients and how I talk to them about venous disease. But at this point, I think we can say that many patients with POTS do well with conservative treatment, and that includes a graduated exercise program. Some patients are very disabled and can't tolerate any medications or exercise, largely because of not only their POTS, but their mast cell activation syndrome. And so in those patients, considering evaluating the venous disease is, I think, worthwhile because we may be able to offer treatments that don't involve medications for them, and that might help improve their quality of life. So with that, I think we will entertain questions.
Yes, absolutely. Thank you very much, Dr. Cutchins. That was very informative. Thank you for doing that with us.
Yeah, of course.
There is, we had little problems with the slides, but I think that got corrected. So we apologize for anybody who couldn't see the slides accurately, but hopefully that got corrected on your end as well. So now we're going to answer some questions. We'll take as many as we can. We're just going to go down the list, Sierra and I, back and forth, and see what we can get to during this time. Thanks everybody who has put forth questions, and you still can do that at the Q&A tab at the bottom of your screen. All right, Dr. Cutchins, how do you treat POTS while having PCOS?
So PCOS is common in my POTS patients. I see it often. I think treating the PCOS often helps a lot. So that would be treatments like metformin and birth control, spironolactone, which many of my patients are on, and it doesn't seem to really bother their POTS symptoms. It's a diuretic, and so it could cause some decreased or increase in urine output. But for the most part, my patients tolerate it well. I hypothesize and wonder at times if PCOS is related to pelvic venous congestion in some way. If those follicles are filling with more fluid than we would expect them to fill with, because there's backup of venous drainage. And I don't know if that's true or not. I have no idea. There's no data showing that, but it's just so common in my population of patients that it makes me think about that. But basically, whatever you can do to treat the PCOS is going to help with POTS.
Thank you.
Okay, I have a question that I think is pretty good and very relevant to a lot of different patients. Does endometriosis make one more at risk for the venous compression syndromes?
Yeah, that's a really good question. So many of my patients also have endometriosis or a diagnosis of endometriosis, because so many of my patients have pelvic pain, right? So I will say that I think a lot of my patients have been misdiagnosed with endometriosis because they probably have something else going on in their pelvis. And that when endometriosis is diagnosed, it has to be done with an exploratory laparotomy. And so you really need the surgeon or the GYN to see that endometrial tissue outside of the uterus. I think there's so much overlap that I wonder if there's a relationship there too between venous congestion and that distribution of endometrial tissue. I don't know if that's a thing or not. We don't know why people get endometriosis. So I mean, if it were me hypothesizing, I would say that there's some relationship there. But there's certainly an overlap in this population of patients, and especially patients who have endometriosis that's treated and has resolved a certain type of pain, but they still have other pain, then that could indicate that they probably have venous stuff going on as well.
All right. The next question is, what are typical side effects from being on vascular drugs? Do any of them eventually go away?
So I guess I don't know exactly what vascular drugs this question is referring to, but we use a couple different things to help with the venous system. There are some supplements, flavonoids, that help with making the veins a little bit more robust and a little bit bouncier or less compressible. Usually patients don't have side effects from those, although in rare circumstances, it can cause a hemolytic anemia. So we look at blood counts while we have patients on those, every 3 to 6 months. There's medications that help move the blood cells through the vessels easier, things like pentoxifylline, which can help sort of with blood flow, and which may help with venous disease. We don't really know. There's also blood thinners. So you can, and sometimes we'll have patients on blood thinners, and, the side effects of those would be obviously bleeding, or excessive bleeding, or any side effect from the medication. Obviously, a lot of patients with mast cell activation syndrome will have allergies to these meds or reactivity to these meds. So that has to be taken into account. I also use, beta blockers and calcium channel blockers in the setting of vascular disease, depending on what the vascular disease is that I'm treating. And, with beta blockers and calcium channel blockers, they can contribute to fatigue. Most of my patients say that their fatigue improves on those medicines because I'm helping decrease their heart rate, but there are occasions where you can have increased fatigue. Calcium channel blockers like diltiazem can cause swelling in the lower extremities, and beta blockers can cause worsening Raynaud's symptoms, or the little teeny tiny spasms that we see in fingertips and toes. And they can also cause some weight gain potentially. So, it just depends on the medicine. That's a little bit of a summary, but it really kind of depends on what we're using the medicine for and what we're treating.
Thank you.
Okay, I've got another one. How often do you encounter comorbid POTS, vascular compressions leading to intracranial hypertension and cerebral spinal fluid leaks?
That's a good question too. So what I didn't touch on in this little talk was that there are venous compressions at the skull base that can occur. You can have jugular vein compression and increased intracranial pressure from that. There's also, it's possible that pelvic venous compression can cause congestion of the spinal column and increased fluid in the spinal space, causing increased intracranial pressures. Patients with POTS, like I had described earlier, often have connective tissue disease. So that the dura of the spinal column or the meninges, what is holding that fluid in, can be weaker also. And so if there is increased intracranial pressure from a vascular compression, let's say, or for any other reason, then you could be more predisposed to having a CSF leak. And so you could have a spontaneous tear in that membrane that can cause leaking of spinal fluid. The CSF leaks are tricky because they don't always occur just from manipulation of the spine. They can occur spontaneously, but they're very hard to diagnose. And it's not an area of expertise for me, but it's definitely a problem that my patients suffer from. And there is some comorbidity there.
Thank you. How do you differentiate between venous obstruction and just extreme blood pooling and overdilation from POTS, mast cell, EDS?
Yeah, that's a great question too. I think there are two processes going on. So one is just venous insufficiency that causes blood to pool in the veins. The other is sort of weakening of those tissues that occur inside, in your leg or in your muscles and in the spaces between your cells that can cause pooling of fluid or extravasation of fluid into the tissues around the veins and around the lymphatic system. And then there's also dilation of veins that occurs from the autonomic dysfunction that's associated with POTS. And so there's a lot of overlap, and you sort of have to tackle all of it at once in order to keep blood from pooling in the lower extremities.
Thank you.
Okay, another question would be, would you change treatment strategies for a pregnant woman with POTS?
Yes. So during pregnancy, we want to limit any kind of medications that are going to potentially harm the fetus. There are medications that we can use in pregnancy. Beta blockers are widely accepted, calcium channel blockers as well. And I often have to use even midodrine and Florinef in some patients with POTS, which is accepted. And obviously we want mom to be healthy and functional, or else we're not going to, have a healthy and functioning fetus. But we do, want to be mindful of potential adverse effects of medications on the unborn baby. So we have to be careful. Oftentimes, I always recommend compression. The higher, the better. You can get maternity compression hose that really help keep blood from pooling in the lower half of the body. Sometimes, in my population of patients with POTS, I'll recommend an aspirin. Aspirin is often used in pregnancy to help with preeclampsia and help decrease adverse events. And I think it's relevant in this population as well. In patients who have a diagnosed compression, we may even use more than aspirin, but that's, just purely, that's not based on any kind of literature. It's just, sort of the thought being that maybe those patients would be a little bit more predisposed to a compression, to a clot from the compression that's already there. I've talked to different people in the vascular world who would say, I just have those patients take aspirin. Some maternal fetal medicine doctors would say, I'd prefer those patients to be on Lovenox. So there's a range. Oftentimes we have to use IV fluids in pregnancy, which is something that I try to avoid at all costs because I don't like my patients to be on regular IV fluids if I can avoid it. Usually I reserve that purely for people who really can't take in enough fluids by mouth. But in pregnancy, sometimes we need to augment that intravascular volume even more. And oftentimes patients have hyperemesis gravidum or really can't take in enough oral fluids anyway. So those are some strategies I use. Obviously keeping your feet up or exercising to the extent that you can regularly while you're pregnant are also helpful.
Thank you. What are your thoughts on stellate ganglion blocks? And have you seen it be effective in treating POTS, mast cells, CRPS, FN, etc.?
Right. Small fiber neuropathy. Got it. So stellate ganglion block is an intervention on the stellate ganglion, which is sort of a ganglion of nerves that, basically sort of decreases sympathetic output. And it's being used some in long COVID. And I've seen it used some in patients with POTS and long COVID. And there seem to be some improvements in symptoms for sure. I'm not sure that blocking the stellate ganglion is getting to the root cause of the issue that is causing the patient to have POTS and these other abnormalities. But I do think that I have seen patients benefit from it. It's just not also an area of expertise. And it's not something I'm commonly recommending for patients because there are some risks involved with that procedure.
Thank you.
Thank you. And I believe you may have already mentioned this, but I just wanted to throw this out there as potentially a quick one. Does strengthening leg muscles improve blood pooling?
Yes, that's I highly recommend leg strengthening exercises. Obviously, the more conditioned your calf and thigh muscles are, the better chance you're going to have for pushing that blood in the vein back up to the heart. So leg strengthening exercises are definitely important.
Great, thank you. Can you talk more about how LDN and how it's used and at what dose? Just some kind of general. We had a couple of questions about LDN.
Yeah, so LDN, I think, became sort of popular in the world of chronic pain to begin with, and patients were being prescribed LDN to begin with, just for chronic pain syndromes. And then what was also sort of discovered is that it's a mast cell stabilizer, and it helps with mast cell symptoms as well, and it can potentially help with fatigue that's related to mast cell activation syndrome. I think in relationship to POTS, anything that helps mast cell activation syndrome is going to help POTS symptoms. So I do use it in my patients. In my opinion, sort of the verdict is still out on how well it really works. Some patients really do find impressive improvements in their symptoms, although I have not seen any patients have resolution of any symptoms just purely on LDN alone. But some patients tell me that it really did nothing for them, and then we stop it. I usually start it at 1.5 milligrams nightly. It can cause nightmares, so it's just something to be aware of, or disrupt sleep. But usually it's well tolerated. I start at 1.5 milligrams at night, and then I go up by 0.5 milligram every 1 to 2 weeks until we get to about 2.5 milligrams. Then I have patients sort of sit at that dose. Usually, I try to see when patients feel any kind of benefit whatsoever from that treatment, and then I stay there for about a month. Because what happens is if you go to the highest dose right away, which is 4.5 milligrams, sometimes you'll miss that therapeutic window. Oftentimes patients really find a sweet spot around 2 to 3.5 milligrams. It may take 4.5 milligrams, but I don't like to titrate it up too quickly because then you could miss that therapeutic window. So that's how I use it.
Thank you.
Thank you. Another question is, Are we more at risk for clots due to blood pooling?
That's a good question. I guess it depends on what the blood pooling is from. If you don't have any compression in the veins of the pelvis, then you're probably not at any kind of increased risk for blood clots. If you do have compression, then you may be. But not all people with these compressions develop blood clots. And so I think you really have to have other predisposing factors to have a hypercoagulable state in order to develop blood clots. And those are a range of things. You know, it could be a true hematologic disorder, or it could be, you know, inactivity, long car rides, you know, estrogen in hormone replacement therapy, or estrogen in oral contraception. That can put you at increased risk. Smoking puts you at increased risk of blood clots. And so there's a lot of, there are a lot of other factors, but blood pooling alone shouldn't put you at risk for a blood clot unless you have some of this other stuff going on.
The next question, mast cell activation syndromes. Is that something all POTS diagnosed people should screen for, or if only if symptoms are present? And how hard is it to get a diagnosis or to get help around that? I know people really struggle with that.
Yeah, that's a really controversial topic, is what I would say. You know, I'm probably one of the few cardiologists that even use those words with my patients and sort of have an understanding of what that is. I think mast cell activation syndrome is very common in patients with POTS. It's not 100% across the board. Every patient with POTS has it, but I do think most patients with POTS have some spectrum of mast cell dysfunction. Whether or not it's mast cell activation syndrome diagnosed by consensus 2 criteria that meets all of those criteria, or if it's just sort of grumpy mast cells, which it could be, I think there's sort of a spectrum. And so I might not be able to officially diagnose all my patients with mast cell activation syndrome, but I do think there's a reactivity component there that is valid. And so in my practice, we use simple treatments like antihistamines, Claritin, Allegra, Zyrtec, and H2 blockers like Pepcid, Zantac, and Tagamet that are over the counter that have very low risk in terms of side effect profiles and adverse events. And we use some supplements also to see if these things help patients feel better. If they don't, then we stop them. But oftentimes we find that even with these mild minimal interventions, we do get improved symptoms. The other thing I will say is that a lot of my patients do better on a gluten-free diet. That gluten as a trigger potentially for mast cells might be the reason why that helps. A lot of my patients also do better on a dairy-free diet. It could be a similar mechanism. And so there are a lot of ways that we can target mast cell activation syndrome that are pretty benign and easy to do, which I think are low risk for patients and could have a high yield. So that's why I really sort of focus on it when I'm treating patients, because I want to make sure that we're not triggering any symptoms with anything that could be modified.
There's a follow-up to that, and that is, you mentioned the GLP-1s as a mast cell treatment. Can you talk more about that and the mechanism for that?
Yeah, I mean, I wouldn't go that far yet. You know, these medications are new and they're encouraging, and patients are losing a lot of weight with them, and they're getting control of their diabetes with them, which is great. In the patients that I have on them who have been treated with a GLP-1 agonist for another reason, like obesity or diabetes, most of them will tell me that they feel like their mast cell symptoms have become better. This is purely anecdotal, and I don't have data on this, but a lot of times patients will say that. And I know other people who are taking care of patients in this realm, you know, in this mast cell world, that would agree with me. They're seeing the same effects. And one hypothesis is that it's decreasing neuroinflammation. So that inflammatory process that's going on in the brain, it's sort of damping that down. And that could be contributing to improved cognitive function and improved fatigue. That's just one theory. You know, it's not ready for prime time for treatment of mast cell activation syndrome for sure, but in patients who could be on it for other reasons, you know, I don't have any I think it could help in other ways, and is basically the bottom line. There is one case report out there showing that with a patient who is refractory to other treatments for their mastocytosis, who took one of the GLP-1 agonists and had a tremendous improvement in their symptoms. So I think there's definitely potential there. It's not, a treatment, but certainly could have benefits if prescribed for other reasons.
Thank you.
Okay, this is a bit of hopefully a quick one too. Isn't progesterone considered problematic for HEDS?
So that's a good question, because the drop in progesterone can make your joints more relaxed. And so when you're hypermobile and you've already got that problem, you can have increased joint laxity. So I find that it's the fluctuations more than increased levels. So if you've got a continuous level of progesterone in your system, if you're on an oral contraception or something like that, it can minimize that bouncing around. And I think that it's the bouncing around, the up and down of levels, that causes increased risk of joint dislocations or tears. This is my theory. I'm not an HEDS expert and I'm not an OBGYN, so I could be wrong. And I don't have a deep dive into the research in that area. But what I find in general is that patients with EDS have more symptoms sort of premenstrually, or have a higher risk of joint issues right before their period, and that's when that drop in progesterone occurs.
Thank you. Would venous obstruction like May-Thurner syndrome always present with pelvic pain, or could it involve only the leg pain?
It could absolutely only be leg pain. In fact, I think it's commonly just leg pain. It could also only be low back pain. The patients I have who have low back pain from this tell me that their back pain gets worse over the course of the day as they're in the upright position, and gets better as soon as they lie flat. Same goes with the leg pain. So you don't have to have pelvic pain to, have a diagnosis of iliac vein compression.
Thank you very much. Can venous pooling contribute to neuropathy or vice versa?
That's a good question. And I have debates with my neurology colleagues about this. You wonder. I don't know. The symptoms of venous disease in lower extremities and venous pooling are very similar to the symptoms of small fiber neuropathy. And you wonder if there's if they're actually the same thing, or if one causes the other. And so I think that there could be significant overlap there, but we don't have any research on that or any data on that. It's unclear, but the symptoms are similar. And I wonder if it's sort of, we're talking about the same thing when we talk about neuropathy and the symptoms of venous pooling and venous disease.
Another question, several people asked about the nickel in the stents, and about mast cell reactions, and what really is involved in the stents and the nickel and so forth.
Right. Yeah, that's a great question. So many patients have nickel sensitivity, and we know that there's significant nickel intolerances or allergies out there. The stents used for the most part are made of nitinol, which is the sort of alloyed metal product. They don't have nickel. In patients who are extremely reactive and have significant nickel intolerances or reactivity, we may send them for metal allergy testing prior to stenting. Dr. Spencer has an ongoing study looking at patch testing of the different kinds of stents prior to implantation to see if there's if you can get guidance from patch testing the stent. So literally taking a piece of the stent and putting it on the skin and seeing if there's a reaction to the stent. It's hard to say if that's useful or not, because the reactivity on the skin and what causes reactions on the skin is different from the reactivity that might occur inside a vein or inside the body. For the most part, and in my minimal experience with this, we don't see reactions to the stents overall. However, it is a very valid question, and it's something that if anyone is thinking about getting a stent or is talking to their a vascular surgeon or an interventional radiologist about that, they should be very clear that they have nickel sensitivity, nickel allergies, and they should ask questions surrounding the risks of having reactivity to that stent, because once that stent is in your body, it's not coming out. And we know that patients with mast cell activation syndrome can be reactive to different things. And so it is an important question to address prior to placing one of these.
Thank you.
Kind of a similar question. Have any of your patients, especially those with MCAS, had bad reactions to contrast dye or other aspects of the testing procedures for venous disease?
Yes. So many of my patients have contrast allergies, not only to iodinized contrast, but also to gadolinium contrast, gadolinium-based contrast that we use in MRIs. None of my patients have, I mean, I can probably count on one hand the number that have had reactions that lasted days. You know, really these patients who got very sick for a significant period of time. I have, you know, anecdotally, maybe one patient who really had a bad reaction to the contrast to the point where it really set them back substantially from how they had been feeling before the test. Most people know if they have a contrast allergy or not. If there is any question, we pre-treat our patients with steroids and Benadryl prior to the contrast exposure, just to try to limit any kind of reaction that might occur. And most of my patients with that pre-treatment do quite well. But yeah, there's always a risk of a contrast reaction or a contrast allergy.
Thank you. Well, we're about at time, and I just wanted to give you an opportunity. Any last thought or anything you wanted to say?
Thank you so much. You know, I know that we could probably do a Q&A for hours here, and I'm sorry I don't have that kind of time. But hopefully we got some questions answered, and we got some, you know, there was a little bit more information that was disseminated about this topic. You know, I guess the take home is that this is still new. This is not, we don't have a randomized controlled trial showing that these, you know, that fixing venous disease helps with POTS. And so, you know, there's a lot we don't know, and a lot that, you know, we're still trying to discover. And so it's, you know, it's an interesting field, and it's an exciting time, but there's still a lot that we don't know.